In this presentation, we will provide a brief overview of pain assessment. We will discuss the advantages of using standardized tools to assess pain, review the pain assessment hierarchy, and discuss issues related to pain assessment in older adults. The questions you ask and how you assess pain will depend on how you plan to use the information, as well as characteristics of the person you are assessing. If you are conducting an assessment of a new client in order to obtain a diagnosis or to develop a pain care plan, the assessment will cover questions such as pain intensity, location, and quality, as well as how the pain began, factors that make it better or worse, or how pain changes over the course of the day. Interference of pain with function or mood, treatments tried and their effect or side effects, and the client's goals for pain management. Ongoing assessment of pain that's needed to monitor a client's status or determine treatment effectiveness requires a less intensive assessment. In this case, pain severity and location of pain are usually sufficient to determine whether changes in treatment are needed. The way we take a measurement can have a big impact on the score. For example, if someone is weighed one day while wearing their clothes, jackets, and boots, and the next day wearing only light clothing, the measurement could differ by 10 pounds or more, even though the person's actual body weight is exactly the same. The same is true for measurement of pain. The words or tools we use to assess pain, or which behaviors we observe, all affect the score that is obtained. Pain assessment is improved by the use of standardized tools. Standardized ways of asking about pain will improve the consistency of measurement between care providers and across settings. Standardized tools make it easier for care providers to document pain scores, to understand what others have documented, and they allow clinicians of many disciplines to evaluate the effectiveness of pain management. In addition, hospitals or long-term care homes can use audits of standardized pain scores to determine if additional resources are required to support staff to better manage pain. Since pain is a subjective experience, self-report is the most valuable means of obtaining information about the pain experience. Attempts should always be made to obtain self-report of pain from all clients. However, when self-report is absent, other methods should be used to obtain a regular pain report. Inability to self-report must be documented clearly in the clinical records, with an explanation of what the limitations are and what alternative is to be used. If the older adult is unable to provide a self-report, look for potential causes of pain, such as arthritis, a wound, or history of chronic pain. Many healthcare diagnostic and treatment procedures also cause pain, such as wound care, rehabilitation activities, positioning, and blood draws. A reasonable cause for pain requires an intervention, even if obvious pain behaviors are not observed. In the absence of self-report, observation of behaviors using a standardized tool is the next best approach to pain assessment. If you are unable to use a standardized behavioral assessment tool, a proxy report can be provided by close family members or a healthcare provider who is knowledgeable about the older adult's usual pain behaviors when in pain. The fifth step in the hierarchy is to attempt an analgesic trial. This should be initiated if pathologic conditions or painful procedures exist that are likely to cause pain, or if behaviors continue to be present after attention has been given to meet the older adult's basic comfort needs. The analgesic trial should be based on the types of pain, the estimated intensity of pain given the situation, and the client's health and analgesic history. Clients unable to use the 0 to 10 numeric rating scale may be able to quantify their pain using a verbal descriptor scale and indicate if their pain is mild, moderate, or severe. Or they may prefer a faces scale to point to the face that represents how much pain they feel. Remember to use a word that is meaningful to the client and try words like soreness, hurt, or ache if the word pain is not acknowledged. It will be easier for an older adult to answer questions about their current pain or the pain they feel right now instead of asking the client to recall pain they felt earlier that day. Allow the client additional time to respond to your questions and use verbal prompts to keep the client focused if necessary. If the client has limitations in vision or hearing or is easily distracted, ensure that hearing aids or glasses are in place and that the client is in a non-distracting environment. A problem may arise if the client doesn't understand the question about pain. Here's an example of a client who has misunderstood the direction of the numeric rating scale.
So, are you feeling any pain right now?
A little pain in this knee, yeah.
Okay. Well, if we rated your pain on a scale of 0 to 10, 0 being no pain and 10 being the most pain possible, what rating would you give?
Probably 7 or 8.
That seems like a lot of pain. If you weren't experiencing any pain or discomfort, what rating would that be?
Well, I guess that'd be a 10. 10's always the best, right?
In this case, the nurse would restate what the anchors mean, or the nurse may choose to use a different scale, such as a FACES scale or a verbal descriptor scale. Let's watch.
Let's try a different way to measure your pain. Can you describe your pain using one of these words? Is your pain mild, moderate, or severe?
I'd have to say moderate. It hurts quite a bit when I move, but it's not so bad when I sit still.
In this example, the client was able to use the verbal descriptor scale and provided more information about the variability in pain with movement. The nurse would document the client's pain as moderate and add extra information in the nursing notes about the difference in pain during movement and rest. To summarize, standardized tools improve the reliability of pain measurement and communication between care providers. The choice of pain assessment tools depends on the client's cognitive and communication abilities, but self-report is the first option on the pain assessment hierarchy.